Hello, everybody. My name is Horst Neuhaus from the Evangelische Krankenhaus in Düsseldorf, and have a great pleasure to moderate this webinar together with Alex Meining from Würzburg. And we have a very interesting subject to discuss: resection techniques in endoluminal surgery. And I welcome outstanding speakers, so really experts in this field. Barbara Bastiansen from the Amsterdam UMC, then Karel Caca from Ludwigsburg, and my co-moderator Alex will give the second presentation. So we are grateful to Ovesco, which is, of course, a company that is very much involved in new technologies for endoluminal therapies, and in particular also full thickness resection, but also other resection techniques. And I think I'm very much convinced that all of us will learn a lot this afternoon. So we have 3 lectures, short discussions in between, and then finally a Q&A period. So it's scheduled for 1.5 hours. And saying that, I would like to ask Karel Caca to give the first talk on Hybrid-EFTR-EMR full thickness resection as advanced resection techniques for GI neoplasia. Karel, thank you very much for participation. We are looking forward to your talk.
Horst, thank you very much for, for the introduction. Let me just have a look. Where's my presentation?
So Karel and his team are really pioneers in this area and worked a lot together, especially with Ovesco, but also with other companies. And you probably know that these are the principal investigators of the German registry, a large registry, and probably Karel will refer to the data using the Ovesco full thickness resection device. And it will be very interesting what can be achieved in various areas of the GI tract.
Okay, so Hybrid-EFTR-EMR full thickness resection for advanced resection techniques for GI neoplasias. We've come a long way for resection of benign lesions in the GI tract, especially in the colon. We have very sophisticated resection techniques, polypectomy having been around for a very long time, EMR and ESD, which is a little bit more tricky and mostly in Southeast Asia for non-rectal or upper GI lesions. And there's the question, have we done all our duties? If we look at this study, are we 100% sure that we are doing the right thing? Are we 100% sure that we are resecting everything? So there's this big study from Paul and his groups from the Dartmouth College. They did a prospective trial at 2 centers with over 1,400 patients, and they've looked about the completeness of resection in adenomas up to 2 centimeters. So rather smaller lesions, and as you can see, 15 to 20 millimeters is a 23.3 rate of incomplete resection, which is statistically significant. And especially for sessile serrated lesions, 31% in piecemeal resection and in difficult resection circumstances. So there's an unmet need for completeness of resection. And this has been verified by a meta-analysis just published online ahead of print by Daniel von Rentren's group at Montreal. They looked at 32 studies in over 9,000 patients, 9,000 polyps in 6,000 patients, and they confirmed this prospective study. They've seen that the sessile serrated adenoma is in a much higher frequency for incomplete resection rate, 28.5%, in lesions smaller than 2 centimeters. And there's a clear difference between up to 1 centimeter and more than 2 centimeters. There was no difference concerning hot snare or cold snare resection technique. So even in small polyps, we have an incomplete resection rate of up to 20%. So what do we do with the larger guys, with the adenomas larger than 2 centimeters? If we go for EMR, we clearly are not able to EMR resect most of lesions larger than 2 centimeters. Then we switch to piecemeal resection technique. Like in this case, you see this large lateral spreading lesion, a mixed type in the rectum. We've done this in a trial, in the Perla trial from Thomas Rösch, and you see you can nicely remove it. We have a 1-year follow-up and no recurrence. So is this the way to go? Or should we all do ESDs like in Southeast Asia, especially the Japanese groups? And if you look, so EMR, so if you've seen it in the large, in this case, done this resection in 35 minutes, it looked complete, and but the recurrence rate for EMR is higher than for ESD, but also the complication rate is higher for ESD, and especially the procedure time is much higher in not so experienced, and it's, I guess, even longer than that. Can we somehow look at the risks for submucosal invasive cancer, for covered or overt submucosal invasive cancer? The group of Michael Berg published this data. They looked at a large series of 1,712 patients in flat or sessile or lateral spreading lesions. And they've seen that if it's rather on the right side, if it's got a granular type histology, then there's a very, very limited, very extremely low risk that there is cancer. The high-risk lesions is on the left side, and this non-granular type, and especially in the depressed lesion, that haven't so looked, especially in this depressed area. So these are the type of lesions we should probably rather go for ESD or some other technique where we can be really absolutely sure that we have removed the whole lesion. Coming back to this ACE trial, this Australian colonic endoscopic resection trial. This was a landmark trial published in 2015 in Gut, where the group of Michael Berg also looked at prospectively at over 1,000 patients and did EMR or piecemeal EMR and looked at recurrence at 4 months and at 16 months. And they've shown, of course, a higher recurrence rate of 16%, but most of it could be handled endoscopically. 16% recurrences after 4 months could be endoscopically resected in 94.5%, and it came down only after 16 months. It got only down to unable to resect, that 2 patients went to surgery. And the patients after 4 months without recurrent adenoma, still 17 had recurrent adenomas after 16 months. And only 1 patient had to go to surgery. The other ones were handled endoscopically. So only 3 patients needed to go to surgery. None was invasive cancer. And it could all be done with piecemeal EMR and non-ESD or other resection techniques. So, but we cannot always solve everything with EMR and ESD, especially if we have scarring or we have a non-lifting sign due to malignant infiltration of the upper submucosal layer, or we have scarring, especially after previous EMR or polybectomy, or if we have difficult location of this lesion, like at the appendical orifice in the diverticular or behind a kinking or a fold or subepithelial tumors. There we clearly need full thickness resection techniques. And the current resection technique for full thickness resection, for endoscopic full thickness resection, is the FTRD device by Ovesco. I think everybody is familiar with it, with this cap. And this grasper, where you grasp the lesion, pull it in, you apply a full thickness clip and snare resect above it. But it's not 100% R0 resection. We've done this wall resect study at 8 centers in Germany, and we've seen that in lesions above 2 centimeters, there was still an R0 resection rate of only 58%. So for up to, so the larger than 2 centimeters is clearly not the way to go alone. We just got our paper accepted this last week of this registry, this German colonic FTRD registry. And in this registry with over 1,000 patients, we could not confirm somehow this data from this prospective trial. There was no difference of lesion size larger than smaller than 2 centimeters. My guess is that the lesions that were larger than 2 centimeters in this group were 2.5 or up to 3 centimeters. And in this prospective trial, even larger lesions were tried to resect completely. So we have a clear signal from the prospective trial that up to 2 centimeters is a good way to go with the FTRD device, and that for lesions larger than 2 centimeters, we need some kind of an additional technique. So our problem currently are these partially non-EMRable lesions and the lesions that are too big to FDR in en bloc resect. What are these lesions? Too big to FTRD en bloc resect are these clearly above 3 centimeters, and even those with 2 to 3 centimeters are sometimes not really R0 resectable. And those non-EMRable are those that you have a scarred area in this polyp, which you not necessarily see at the beginning of your resection, and you currently run then in problems that you cannot lift and you cannot completely EMR resect. Or if you have a lesion at a difficult location, like at the appendical orifice. So there is, I think, a technique that's very attractive. This is a combination technique using the FTRD device to do first an EMR around the non-lifting area of this lesion, and then do an additional full thickness resection with the FTRD device. Let me give you an example. So this was a lesion that was at the cecum, not involving the appendical orifice. And you can see I started out with lifting the lesion, and I did a nice EMR, and I thought, okay, so I will be able to EMR resect the whole lesion. And proceeded, everything looked nice. But then currently I saw this area that was non-lifting. So I still was able to resect most the margins of this lesion. And then I went in with the FTRD resection device. And everybody's familiar with it, and then just grasped it, pulled it into the cap, and then snare resected, as we all are familiar now. The resection specimen, you can see the margins are adenoma free, and you see the resection specimen. Another example is here at the appendical orifice, this lesion at the appendical orifice, where you also kind of EMR resect, that make it a little bit faster. And then you finally have everything removed except of the appendical orifice. Then you also then grasp, pull in, and resect the lesion at the appendical orifice, and so complete your resection. So it's not an R0 resection because the pathologist cannot confirm it, but it's a complete resection. Was the picture after the resection. We published data on our first 10 patients in 2017, where lesions up to 4 centimeters, where we did this hybrid technique. We encountered no complications, and the follow-up was very short at the moment. So we are currently putting our data together for our other patients we've seen at our clinic, and this is a 32 at currently. We have 4 left-sided lesions. We have 28 right-sided, 12 were in the cecum. The procedure time was 40 to 140 minutes. The 140 was in the beginning of the procedures. We had no major complications. Benign lesions, so also here again, no 100% recurrence free, but still those could be handled with another FTRD resection. So let me conclude. I think we can now nearly 100% resect all benign colorectal lesions, and we've come a long way. If you can imagine, when I started, there was still like 10-20% large lesions still going to the surgeons. And I think this is really worth a 3 times a hooray, because this is nearly all lesions in the colorectum can now be done endoscopically. I think we should aim always for complete resection, but this doesn't mean always en bloc resection, because we are handling benign lesions mostly, and it's not necessary to do a 3 to 4 hour procedure just to be en bloc and in danger of perforation or bleeding. But still, we should know our limits. We should look for signs of overt submucosal invasive cancer. That's a depressed lesion, I think, and I think only the depressed lesions should be sent right away for surgery. The other ones, we should look for resection. FTRD, EFTR, so using the FTRD alone, I think that closed a major therapeutic gap for us, and this is standard procedure technique in most endoscopic centers. And Hybrid-EMR FTRD is closing a small but important therapeutic gap, because it's the logic next step when you're in trouble. The FTRD devices for those lesions where you cannot resect with standard endoscopic resection techniques. If you can resect with standard endoscopic techniques, no need to go for any further. But when you're in trouble, like at the moment you're doing EMR and you have a non-lifting area, you can solve the problem, and you can solve the problem right away, and you should solve the problem right away, because otherwise you get scarring, and FTRD in a second session is much more difficult. So let me conclude. When in doubt, take it out. That's what the surgeons say. That's what we also should say, and take it out endoscopically. Thank you very much for your attention.
Thank you very much.
Thank you,
Karel, for your excellent presentation and for showing very promising results. And this is now open for discussion. We have some minutes for your questions. And before the first question comes in, I would like to ask you, how do you currently select patients for EMR, ESD, and FTR? You are an expert in all the 3 technologies. Let's say we have a patient with a 2 centimeter non-granular type of lateral spreading tumor, or a mixed type. So you are 10 to 15% risk of cancer. What would you suggest?
If it's in the rectum, I would go probably for ESD, because ESD is fun in the rectum. You can do it pretty with a dual knife and the new settings from the RB with a precise sect mode. You hardly have any bleeding. It goes really fast. You can now the techniques for ESD in the rectum is improving, and I would go for the ESD. Except we have this study, this Perla study. We are still recruiting for the study. In the colon, I wouldn't go for ESD. That's from my point of view, it's a little bit too risky and too time consuming. There I would really go for EMR. And or if I would have the feeling that it's in a flexible part of the colon and I can grasp it and pull it all into an FTRD device, then I would go for FTRD. But those lesions that have the higher malignant potential are very rarely on the right side of the colon. They are much more in the rectus.
Horst, maybe I would also like to ask Karel a question. Karel, thank you very much. Fantastic data you've shown us. I have one question with respect to the rectal lesions. You mentioned that already a little bit now in your comment to Horst. My personal experience is that the hybrid EMR FTRD in the rectum, even if it's a non-cancerous lesion, is sometimes a little bit difficult, because if there's a big scar, then sometimes you have problems with the FTRD system. Do you have any solutions for that, or any tips and tricks to overcome the problems we might have in the rectum, grasping enough tissue to bring it into the cap for resection?
I think it all depends how far down in the rectum you are. I mean, if you're above the peritoneal line, then it's easy, because then it's flexible. Then you can grasp it in and pull it in. It's easy. And the more further you come down, the more it's tight to the pelvic floor, and so you cannot pull it in, and all you get is a deep submucosal. So in the deep rectum, I wouldn't go for FTRD. So up to 5 centimeters, I never go for FTRD. I mean, this is, even if you do an endoscopic full thickness resection with a dual knife or whatever knife you use, it's hardly any complications, because the rectum is very forgiving.
So you would go for an ESD then, or would you do something like underwater EMR, or always ESD then, or cold snare resection? I mean, we're talking about lateral spreading tumors, granular type.
You could go for underwater. I'm not familiar with underwater. I know the data from Piecemeal, and it looks all very nice, but I'm not familiar with this technique. And cold snaring is getting more popular, even for lesions larger than 1 centimeter. I think for lesions up to 1 centimeter, it's standard pretty nicely. But cold snare above 1 centimeter, nothing I would go for. So for these lesions, I would go for ESD, because you can do it in half an hour.
Karel, there are several questions on the technique to combine EMR and FTR as a hybrid technique. One report from the Netherlands, they had good experience with this combination, as you suggested, but they observed 2 delayed perforations in the right colon about 24 hours after the hybrid technique. And the question is, could it be that after removal of the mucosal layer, the clip can grasp too deeply and is not fully anchored, and could cause then a defect of the wall? And there's another question about the perforation and a suggestion: is it not better to do it as a second stage procedure? Did you have any reports on perforation as that?
I know that there are some reports, but it can happen. I mean, perforation with every resection technique, it's a possibility, but in our experience, we had no. I was also very concerned at the beginning, but I had no perforations in the beginning, and I did some cases as a 2-step procedure, and then you have scarring, and then you have problems to pull the rest of the lesions into the FTRD device in a second session. But since I have never encountered perforations, complications with this hybrid technique, I would go for this.
You showed a case which was not too
but still, perforation is a possibility. It's a possibility. It's always a
It's
possibility,
always a possibility. But in your case, probably at least you attached also parts of the mucosa because you fully pulled the lesion itself, but also the resected area into the clip. But if you have a very wide resection and in the cecum, for example, and you apply the clip just on the thin wall, then it may happen. At least it should be considered. And I personally think it makes no sense to do it in a second step a few days later. It would be, if this would be shown also in other series, then it would be an option to do it after 1 or 2 months after scar formation. I think we should observe this potential risk. Do you agree?
Yes, I would agree, because like from surgical data, we know that it takes about 3 to 4 weeks to have a stable scar in the colon. So it's a stable situation. So you should wait like 6 to 8 weeks, and then you have, but then you have a scarred tissue.
So, and another question, in case of an accidental non-lifting part, in a case that was scheduled for EMR, EFTR can be applied to salvage this case. Would it make sense to get consent of patients right away for possibly needed EFTR when scheduling this case? Do you inform your patients before any type of EMR?
Yeah, if they are referred for advanced resection techniques, I always explain to them all the 3 different techniques, and then tell them I probably will go for this, but I'm not 100% sure. If need be, we of course would switch to another technique to complete the procedure, and I think it's the most interest of.
Yeah. We do the same, and we also have to explain that just in case of even for simple EMR, we always get the consent that if perforation occurs that cannot be managed endoscopically, then they have to know that surgery can be indicated, and therefore EFTR should be implemented in the endoscopic armamentarium. Yeah, I agree. Okay, thank you very much. I think this was very interesting, and we are looking forward to more results. But this really expands our options for endoscopic resection of complicated lesions with non-lifting. And just to re-emphasize, non-lifting doesn't mean cancer, because the non-granular type of lateral spreading also don't lift, but this is just to fibrosis. And therefore, it's very important to characterize lesions and concerning the Sano classification or other classifications, vascular formation, to get an idea if there is an increased risk of cancer. Thank you very much. So now I ask my co-moderator, Alex, you will inform us about new techniques of EMR and ESD.
Yeah, thank you very much. It's a great honor to do this here, and I'm gonna tell you a little bit something about new stuff that maybe not everybody might be familiar with. I also have to regret that there is no data available, no real hard data. So this is more or less a little bit own experience, case-based experience, but it's a little bit also close to what we've heard before by Karel and what we later hear by about the T1 tumors, is that there is not one single solution for everything. I think you have to be flexible, as we are as endoscopists, and find various solutions for various lesions. So enough talking about that. My topic is EMR plus or ESD plus. I will tell you what the plus means. And maybe, I don't know, maybe we have to put a question mark behind that it could be an easier and faster method thanks to the multi-channel technique and LiftUp injection, what I will talk later about. So the problem about endoscopic resection, and this is quite similar to what Karel told us before, is that we have good technologies that are very effective, EMR and ESD, and also FTRD, and also Hybrid-EFTR-EMR, but they all have their pros and cons. And if you compare, for example, EMR with ESD, EMR is fast and safe. ESD has a high R0 resection rate, and you always attempt to do an en-bloc resection, which is important for certain types of lesions. You have to be aware that you need to go for an R0 resection, particularly if it's already a cancer. So I will also talk about lesions in the stomach, and not only about colonic lesions. So there are definitely some lesions where we need to go for an R0 resection, and if they are larger than 2 centimeters, then usually we have to do an ESD. But of course, ESD is time-consuming. It's risky, and also the R0 resection rate is not always 100%. And we have good data from the Japanese, but we also have some data from Western countries where we have about 70% of R0 resections. So the question is still, what might be a good solution to do an EMR or SD, or maybe something in between whatsoever? So if we go back to the past, maybe, and this is a cartoon that's based on a technology that is, I think, 2 or 3 decades old. That's also was firstly developed in Japan, where they had that sort of grasp and snare technique, which was used before the Inoue cap technique. So here a dual channel endoscope was used because the endoscopists at that time found out that you need something to lift, you need something bimanual, that you have one arm where you can lift the lesion using a forceps, grasping forceps, and then you have another arm where you can apply the snare around the lesion and then resect the lesion, because by doing so you have a better chance of doing an en bloc resection of lesions that are larger than 2 centimeters, in contrast of just using a snare where you have piecemeal resection in these cases. Nevertheless, the disadvantage with these or this rather old technique, and this is probably also the reason why it was not really used and it has not been reused over these decades, is that the standard dual channel endoscope, they have some limitations. There's a small distance between the channels, which makes it sometimes even more difficult to use the 2 instruments in these endoscopes. And of course, certainly they're not available everywhere. If you ask somebody, do you have a dual channel endoscope? And then you see maybe half of the audience raises their hand, and then you ask how often are you using that? And then people say hardly ever. So this is certainly a limitation. And then the idea was some sort of that maybe there would be something in between, so that we have a second instrumentation channel that has the advantage that you don't have to have a special dedicated endoscope for that, so that you can just put it on any sort of endoscope, so that you don't have to buy a new special dual endoscope. And also maybe by having something like this, the additional working channel, that's what it's called for, that maybe this has also other advantages. And this is just now a movie showing you how is it looking like. So this would be now for ESD plus. So you have a knife, and then you have a grasping forceps that is introduced through the additional working channel. Of course, you can see that you cannot really steer these or do an independent maneuver with these 2 instruments, but there is one large advantage in comparison to the standard dual endoscopes, as you can see here. So here on the left side, you see that this is a standard dual channel endoscope. Oops, I'm sorry. And you can see that the distance between the instruments is quite small. And the reason is because the endoscope has some certain limitations. Even it has a larger diameter, it has some limitations. So what you're only able to do when you use this one and you do a grasp and snare technique, as shown here, is that it's very difficult to have some sort of traction or counter traction. You're working in a very parallel fashion, and traction and counter traction is hardly impossible or very difficult and cumbersome. And this is now the same, or rather identical image with the AWC. And I think here you can see the difference of the concept. So you have a much larger distance between the two channels, and they're also opposing each other. So they're not going out parallel as here. So the other one goes out here at the 1 o'clock position and the other one at the 7 o'clock position. So what you can achieve here is that you have a maximum distance between the two instruments you are using. And by having this maximum distance, you also have the possibility to have some sort of a, not only working in a parallel fashion, but maybe also in an en face fashion, that the snare is placed differently as seen in this image. And I also show you a clinical example quite soon. So this is the concept of the device, and it has been on the market now, I think, for 2 years, but there's still some limited experience on that. We also perform courses on showing that technique. It has some advantages, but it also has some disadvantages. And maybe one disadvantage of that procedure when you do the so-called EMR plus, as I mentioned before, I will show you a video later, is that you are able to have an en-bloc resection of really large specimens of up to 45 millimeter, which is very big. So these are patient data too. This is not animal data. These are patient data, case series. So you can really have large lesions where you do an en-bloc resection, even in the ascending colon or the transverse colon, not only in the rectum. Even there where you might expect it's a little bit more risky. So you can do large specimen EMR with this technique. However, the problem is that our zero resection is not always possible. The reason is that because if you pull back the lesion into the snare, then you don't have a full optical control of whether you had the whole lesion or maybe there's still a small fragment left. We still are using that device for that technique. I just did a case last week. It was a large polyp in the sigmoid. And then, of course, you have one big specimen of about 45 millimeters, but you cannot be sure whether you have really R0 resection. So, of course, there are cases where you really have to go for en-bloc resection, and you have to be certain that there is indeed an en-bloc resection. And this is particularly for cases where you know there is a cancer and not only a low-grade intraepithelial neoplasia. So in the same case series, we also did 4 ESD plus. I would just show you soon what you can understand with that, what's that meant. And there was no difference with respect to the size, but when you do the ESD plus method, you have R0 resection in almost all cases in these early series. And we also confirmed that in many other patients we have done now since we have the device available after publishing this first case series. So, and then, of course, there is also something else. It's the injection technique. I'm sorry for the typo here. This is so-called LiftUp. And we have been waiting for LiftUp quite a while. We did several courses and we used it many, many times in the pig because we felt that this is really an advantage that you have an injection solution that you can inject, but then you have a longer cushion to enable endoscopic resection. And this is LiftUp, and LiftUp has some sort of it's cold and you store it in the fridge, and as long as it's cold, it's liquid. So then you can do an injection. And as if it's getting warmer, as in the human body, so if you have a temperature of 37 degrees, it's more a gel-like substance. So what we experienced now is for ESD, and this is also potentially true, you have a better cushion and you probably need less re-injections doing so. For EMR, it has some pros, but it also has some cons. The pros is, and I will show you this in a video, I think it's in the next slide, that in my opinion, it's ideal solution for this sort of knife-assisted resection using also the additional working channel. Sometimes if you do a EMR of a smaller lesion, you have a very big cushion in the submucosa that is rather hard because it's a gel-like substance. And sometimes it's then almost more difficult to place a snare around it in contrast of just using stained saline. However, as mentioned before, if you do this sort of knife-assisted EMR plus, then I think it's a fantastic solution that helps you definitely. So these are also some further images on this new substance called LiftUp that combines perfect with the EMR ESD plus technique. And you can see this is fluid here and this is in the fridge. And then when you inject it, and then it's really getting more this gel-like substance that is rather hard and stays there as long as the body temperature is, as long as the temperature is about 37 degrees. So now, having talked enough about theory, now what about clinical practice? So here, this is an early gastric cancer in the incisura angularis. And as it's a cancer and it's in the corpus, you should go for a definite en bloc resection. Maybe I'll make a small break here. And do an ESD because you really want to have a good histological specimen and you want to be certain that this is fully removed with all oncological standards adhered to. So what you do here with this ESD plus technique, you start identically to any sort of ESD. You demark the lesions, you put your marks around the lesion, and then you start with a small injection of maybe 2 milliliters of saline just to see where you are. Oh, I'm sorry. To go back. And here we are. So you inject the saline, and once you're sure you're in the right layer, then you inject the LiftUp, and then you could see already that it's coming out of these marks. And then you have a very, very stable fluid deposit there. And then you do the circumferential incision is here. All the same steps as you do with conventional ESD. This was the aqua knife I was using here. And then if sometimes you have areas where you have problems having enough space for the further resection. This is where the ESD plus technique is then performed. And here you just use the additional water channel. So you don't use a cap that you really sort of dive into the submucosa. You have then this additional working channel that helps you to retract the lesion to have then enough space to do the submucosal decision. And what you can also see here is one of the further advantages using that device is you can see you have here this in the 8 o'clock position and the knife in the 2 o'clock position. So you can be flexible with your positions. If you have the lesion that's maybe on the top of your image, then you can put the knife into the additional working channel, meaning you here, as shown here, at the 2 o'clock position. And then you have the retractor or the grasping forceps at the 8 o'clock position. If it's vice versa, then of course you can change your instruments. Or if you have to change your position, maybe once you do in a retroflex and then you go back to a standard position, you can change the channels. So you just pull out the knife from the additional working channel, pull it into your standard working channel, and the vice versa with the grasping forceps. So this is the concept of the ESD plus. And then you can apply with the grasping forceps some tension on the tissue, which helps you to enable the ESD. Quite safe in my opinion. I don't have very robust data on it. It's more a personal experience, but you have a better distance And the cutting plane is, so you put some tension about it. That's more a surgical principle. And then you can really progress rather fast with your endoscopic submucosal dissection, because you don't have to be so afraid that you are getting too deep and then you might cause perforation. So here you just put some tension and then you change your position again, cut with the knife, and then you finish quite soon. Probably all those doing ESD, that particularly at the end of the procedure, the risk of causing a perforation is rather high. And here it's quite easy, because you always have a larger distance. And then it's just done as in any sort of ESD, regardless whether it's an ESD or ESD plus, is that of course you take care of the bleeding vessels by using a hot biopsy, for example, as shown here. So this would be the ESD plus technique, which I think is very good for many, many locations in the stomach. It's also good for Barrett's, I think, because there you can really push away the tissue a little bit. For squamous epithelium, sometimes there is not enough space, so I would refrain a little bit from there. But particularly early gastric cancer in the stomach, regardless where the position is, I think it's a quite good technique. So what about EMR plus? This is another case, and this was a lady that had hyperplastic polyp and a recurrent hyperplastic polyp. However, then in one biopsy, so she was referred to us for endoscopic resection of the polyp. In one biopsy, she had also an adenoma. And the concept in these polyps is also that you try to achieve en bloc resection, not so much because of the histology, but more that you really are sure that there are no remnants left to avoid the risk of recurrence of these sometimes very large hyperplastic polyps. So what was done here? Same thing at the beginning, injection. So just a small amount of saline, then the LiftUp. You can see there was a nice, now here's the LiftUp now after saline, and you can see there was a nice cushion. And then here I did the so-called knife-assisted resection, which was not knife-assisted. I just used the tip of the snare, so it saves you also some money. And then you can be quite safe doing the cutting, because you have a very nice cushion of that LiftUp. And this is really an advantage in my opinion, because you can do the circumferential injection just using the tip of the snare. So almost done here. I did some sort of a re-injection. You don't have to do 100%, sometimes also an 80% or 75% at circumferential incision is enough. And now you can see the snare coming out of the additional working channel in the 1 o'clock or 12 o'clock position. And this is now placed. Now you can see the big difference in comparison to a standard dual channel endoscope, that you have a lot of space available here. And you place the snare exactly where you do the circumferential incision before. Then you place the grasping forceps through the standard instrumentation channel, pull out the lesion, pull the lesion into the snare, close the snare, and then do the resection. And then what I said before, you don't see exactly whether you have anything in there, but if you did the circumferential incision, I'm sorry, before that, you can be quite certain. And this was a 5.4 centimeter large lesion, which as known before was a hyperplastic polyp, but had also some adenomatous areas in the lesion. So I think these two videos were enough to show you the concept of the ESD plus and also EMR plus technique. What, however, I think is important is, and I think Horst, you also mentioned that before, you really have to know what sort of lesion it is. Is there a deeper infiltration? Is it a cancer? Is it an adenoma? Is it low grade? Is it high grade? Where is it located? So one of the most critical issues is that you do your diagnostic endoscopy and be certain before you do the resection what might be the ideal sort of resection, depending on the location, the type, and the size, and also the morphology lesion. I think we have to get away from the dogma that we have to do ESD only. There is no reason to do ESD only. And even if it's a large lesion, then it's some sort of, it's not necessary. And it's also, you cause some risk for the patient. So you have to know before what is necessary and what's not necessary. And of course, if you have a cancer, as mentioned now, I think several times before, you should do an ESD, but then the question is, does it have to be the classical ESD, or maybe also some sort of an ESD plus, as shown before, that you use the additional working channel, and maybe also the LiftUp to feel a little bit more safe. And maybe, as I said before, I don't have enough data to prove that, but maybe feel a little bit more safe, be faster, and have a lower risk, lower procedure-related risk. Of course, of note, the oncological outcome is that what counts, however, causing the lessest risk as possible. And I think I've shown you now, and this is also one of the concepts of this whole webinar, that there is not one method that fits all. There are several methods available. There is Hybrid-EFTR-D, as we've heard before. Then there might be EMR plus, there might be ESD plus, in combination with the additional working channel and LiftUp, that I think open out new options for endoscopic resection. And I think this is very important, that you have several tools available, that you have several options available, and then decide what might be the right method doing now the best endoscopic resection with related to a low risk but adequate oncological outcome. And most important, of course, is don't use only one technique. Look a little bit behind the horizon and become familiar with these options, and try to increase your own experience working with them. That's it. Thanks a lot.
Thank you very much, Alex, for your very interesting presentation showing very promising new devices, and also thank you for your balanced conclusions. Now, this is also open for discussion, and I would like, I have two questions and two comments. So if you use AWC for colorectal lesions, doing a combination with EMR, is there not a risk that you lift too much? I think it's very difficult if you have a large lesion. There is, of course, you're tempted to resect it en bloc.
Yeah.
And how to avoid the risk that you entrap muscle layer. Yeah. There are data also from Japan reporting on the combined technique, so circumferential incision followed by en bloc resection with a snare, yeah, which also showed high risk of perforation.
Yes. You can reduce the risk by two aspects. The first one is that you use LiftUp or something similar, so that you have really a nice stable cushion to minimize that risk. And then what's also important, and this is also part of the technique, and Karel is also be very well aware of that, is that when you close the snare, then you have to push back a little bit. This is the so-called push-back step. That's a part of that EMR plus technique that you really try to avoid to have the muscle layer inside of the snare. So I would say maybe three aspects. The first one is a stable cushion, such as with LiftUp. Second is push back before you close the snare a little bit. And then also do a circumferential incision, because then the snare has a better position in the lesion. But still, so far I was glad I did not have any perforation, but of course it's always endoscopic intervention. There's always a risk. You just have to try to minimize this risk. And I think the these three aspects might be some sort of helping you to decrease the risk.
There is a question for LiftUp. So those who did ESD with LiftUp get the impression that we see more frequently bubbles
Correct.
at the resection area combined compared to using other solutions, saline or hyaluronic acid.
Yeah, absolutely correct. This is definitely true. What you can do is sometimes you put a little bit of Simethicone in your water flushing. That helps a little bit sometimes. And also when you do the ESD plus technique, as shown before, the difference is also that you do not really create a tunnel in the submucosa. So it's more a more surgical approach, that you have one arm pulling away the lesion and the other one cutting it. So it's not so relevant because you don't have this large view in the submucosa where you see those bubbles. So for the ESD plus technique using the AWC, it's not so relevant because the distance to the cutting plane is different as when you do a standard ESD, but that's true. Bubbles are definitely present using the LiftUp, and Simethicone might reduce it a little bit.
What are your recommendations for those who would like to start with this technique? Which are the appropriate lesions?
Mm-hmm. Yeah, I would say the stomach is good to start with. Rectum also. I think my first case was also in the rectum because we have more rectal lesions as gastric lesions. Stomach is good to start with for ESD plus, and rectum also for ESD plus. For EMR plus, I think the same holds true. And once you get more familiar, you can get more a little bit to the proximal colon. So meanwhile, I also do it for the transverse colon and also for the ascending colon. But then I do the knife-assisted resection. So meaning I do a circumferential incision before I place the snare, and then I do the pullback technique as mentioned before.
Alex, I think the main competing technique for AWC is using commercially available clips now with loops.
Yeah.
You can even use simple rubber bands.
Yeah.
And clip depending on the location, the proximal or distal margin of a lesion after partial resection, and hook it on the contralateral wall, which also gives nice lifting, and it's quite easy and in particular inexpensive.
Absolutely true. Helps a lot, and I also used it quite a lot. The only disadvantage I see is once you have the clip fixed with the rubber band or the string, then you have it only in one direction. And the advantage with the AWC, which is not so expensive, is that you can change the direction. You can also not only pull, you can also push, which sometimes helps, depending on the location. So with a rubber, you just have it fixed on one side, and then that's it. This is the difference with the AWC. And then another difference or advantage, in my opinion, is that you can change the instrument. So sometimes you have problems that you really always go too deep, and then you're looking for something to have maybe an instrument at another position. And then you can just change them, exchange the knife and the grasping forceps, and put the grasper in the regular instrumentation channel and the knife in the AWC. So I think you have more flexibility in comparison with the rubber band or the tooth string method.
Okay, thank you very much. Very interesting. And we are now looking forward to the last presentation from Barbara Bastiansen. And Barbara, we asked you to talk about FTR and T1 tumors, probably in the colorectum. Yes.
Thank you very much, Horst, and thank you all for at home or wherever you are, at work, maybe on holiday, for watching this presentation. I'm very delighted to be able to give this presentation, one of my favorite subjects. EFTR in T1 cancers with the FTRD device. And so what I would like to tell you is, see if I can get the next slide. Yes, as you all know, T1 colorectal cancer is in the spotlights. First of all, because its incidence is rapidly increasing due to very effective screening programs that we have now. And so up to 40% of all screen-detected cancers are actually T1 cancers at the moment. And we get very enthusiastic about that because we are endoscopists with a surgical interest, because we can get a potential endoscopic cure, since the overall risk of lymph node metastasis is relatively low in T1 cancers, of course. Well, the critical first step to get a curative endoscopic resection for T1 CSE is, of course, radicality. We need to have an en bloc R0 resections with a clear resection margins, the lateral as well as a deep resection margin. So that's the main important step, because the next step is hard for us as endoscopists to predict. Of course, we need very precise histological assessment of all risk features that need to determine whether the patient is cured or needs additional surgery. To do so, to start with, it's very important that we recognize early cancers before we resect them. Now, that seems to be a problem in current practice. Jasper Vleugels, together with my colleague, Professor Evelyn Dekker, studied 91 T1 colorectal cancers within our national bowel cancer screening program. Over 3,600 colonoscopies were screened, and these 91 T1 cancers were found. And what they found was that the majority of cases, so 61% actually, were not recognized as T1 cancers. And this led to inappropriate resection techniques like cold snare polypectomy or even piecemeal resections in over 30% of the cases. And what they found was that these inadequate resection techniques led to the overuse of surgery in the non-correctly recognized cancers in 41% versus only 11% if the cancers were correctly diagnosed. A second paper in Gut from this year from another group, Dutch colleagues, found actually the same picture, that in 150 T1 CRCs, the majority, in this case, even close to 80%, was not correctly recognized. And that led to a high number of our incomplete resections, R1, Rx, as we say. And in those cases, 44% missed potential endoscopic cure. That's a pity, of course. And I think we all face this dilemma very frequently in our multidisciplinary meetings, because, of course, although surgery is the traditionally considered the reference standard for the therapy and for staging of T1 colorectal cancer, it comes with a price, and this price might be higher than the actual benefit for patients, especially when we consider age, comorbidity, the patient's wishes, and the tumor biology. And we must remember that over 90% of all cases are overtreated with surgery. So there's a lot to win here. And of course, to have a decent conversation with your patient, to make a shared decision whether your patient will benefit from surgery, what we need is precise histopathology. And this is not a corona-proof pictures. We don't shake hands at the moment, but of course, if we have a safe R0 resections with a very precise risk assessment of all risk features, then we can have a good, only then we can have a good conversation in our daily practice. So of course we have ESD, as we discussed before, beautiful techniques, delivers very good histology and high R0 resection rates in experienced hands. It can give a potential curative treatment for low risk T1 cancers, and it has unlimited size, but it also has downsides, of course. It's, I think colonic ESD is one of the most technically demanding procedures. There's only few endoscopists outside Asia that are skilled enough to do so safely. And another important downside, I think, from ESD, that it's inappropriate for deep submucosal invasive cancer. Because as you know, in ESD, we cut through the lower third of the submucosa. So you can imagine if a cancer is invading deeper in the submucosal layer, the risk for an incomplete resection at the deep resection margin is quite high. And I think this is a very important slide that I would like to comment on, because now the evidence is really accumulating that deep submucosal invasion is not a strong risk factor for lymph node metastasis. So in fact, if you have a tumor that only has deep submucosal invasion without any of the other risk factors, like lymphovascular invasion and tumor budding, etc., the risk for lymphatic spread is actually only between 1% and 2%. So these are a collection of the studies being published between 2012 and 2019, and they all show the same image. If you have adequate histology, where you can look at all these risk factors, actually the risk of lymph node metastasis indeed varies between 1.2 and 1.7%, and that does not weigh up to the risks of surgery in many cases, where the risk of dying is about almost the same. So if this is true, and if deep submucosal invasion is indeed not a strong risk factor for lymph node metastasis, then a safe transmural endoscopic resection for deep submucosal invasive cancers might change our traditional paradigms in treating cancers. We just need to dive a little deeper. So here I would like to show, I think probably the whole technical aspects are known, but I'd like to show this small T1 cancer in a 75-year-old in the ascending colon. Here on MBI and near focus, we clearly see a demarcated depression with a very irregular Kudo type 5 pit pattern, probably a JNET type 3 lesion. Here the lesion is being marked. The FTRD is being loaded, the grasper comes out. Grabs the tissue. And then by pulling slowly, you see here the colonic wall is nicely mobile, and we need to take some time, but then it really mobilizes into the cap with all the markings. When the cap is a little bit filled, we apply some extra suction. Then here the clip is being released, white ring being pushed forward, tissue resected, and then comes out, and we need to pin that down for histological assessment. And then after going back in again, we clearly see that we've made a full thickness resection. And then this is the final histopathology for this case, showing indeed, as you can see, a full thickness resection with a clear proper muscle layer underneath the tumor. And the tumor here is very close to the muscle layer, but is not invading it. There's a so this is a deep submucosal invasive T1 cancer, and did not show any other additional risk factors like budding or lymphovascular invasion. And we decided together with this patient to stay in close surveillance. The patient did not want additional surgery. And now we are 2 years later and he's still in a good condition. This is a more close-up picture of the tumor. Actually, pathologists, I mean, this is the best a pathologist can get for histology. They love looking at those images, of course. Another case to indicate the additional value for full thickness resection is this guy I met a few years ago. He already had a cancer in his sigmoid, and an open sigmoid resection with an anastomosis at 15 centimeters when he was 40 years old. And then in the referring hospital, a follow-up colonoscopy was performed with a piecemeal resection of a high-grade dysplastic polyp. No follow-up was performed, and then he came back for a surveillance colonoscopy, and these are the referring pictures on the right side showing an ugly lesion in the descending colon, which didn't lift properly, but well, the referring doctors attempted a piecemeal resection and marked the lesion with a tattoo. And then histology came back with being at least high-grade dysplasia with a strong suspicion of submucosal cancers. And then talking to the patient was really in doubt what to do, because a second oncological resection would mean a subtotal colectomy with an anastomosis probably even below that 15 centimeters. So probably with 10 centimeter rectum left, he would have functional outcome decrease. And so he was referred for a full thickness resection. And this was the lesion that I saw. It was clearly an ugly scar, and although the mucosa seems almost normal, there's something happening underneath the mucosa. Of course, I believe ESD in a case like this would never be safe enough to perform. So we actually performed a full thickness resection, and this is the specimen where you indeed almost see a normal mucosal layer, but underneath the mucosal layer, that's where it's happening. There's indeed a residual cancer up to the muscle layer, but without any other risk factors and clear resection margins. So also this patient, especially for his history, chose not for additional surgery, and we are keeping him under close surveillance. Now 2 years later, he's also still doing good. So another problem we are facing very often is indeed incomplete resection of non-recognized cancers. And literature is showing that the risk for residual cancer in the bowel wall after an incomplete resection is really high, between 6 and 15%. And of course, that's the reason that all international guidelines advise additional surgery for after incomplete resection, even for cases without any histological risk factors for lymph node metastasis. And although we know that many of those surgeries are not going to provide any benefit for the patient. And with a full thickness resection, a scar, if we are able now to take out the full scar, as you can see, this is one example where you clearly see the muscle layer underneath, and you see these pink submucosal fibrosis from the previous intervention. So this is a clear scar here in this submucosa. And we were very lucky in this case because we accidentally also took out one tumor negative lymph node. So we can consider this as the first endoscopic sentinel lymph node procedure. But of course, this was a true surprise. And I must say that in all the cases I did, I only found a lymph node only once. But this was, we were very enthusiastic about this, and also our pathologists. So the first important report on endoscopic full thickness resection for T1 colorectal cancers were from our German colleagues from the FTRD study group. And they looked in their registry, of course, and found 156 T1 related cases. And they analyzed them in retrospect, dividing them in two groups. The first group was indeed the re-resection of scars after previous incomplete resection, 64 cases, and 92 cases of primary non-lifting lesions that turn out to be cancer at histopathology. And of course, the endpoints were technical success, R0 resection, successful risk stratification and complications, etc. And what they found was an overall R0 resection rate of 71.8%, and a very high technical success rate of above 93%. Of course, the R0 resection rate here for the re-resection of scars was higher than for the primary non-lifting lesions, 87.5% versus nearly 61%. But what they conclude was that a full thickness resection was feasible and safe for colorectal cancers, and did lead to very high accurate risk stratification in above 99% of cases. For this talk, it would be nice if I can show you the preliminary results from our Dutch prospective EFTR registry that we started in 2015 with now 23 participating hospitals. Currently we have over 700 registered procedures in the registry, and in Holland a large amount of those, so over half of all these procedures are T1 related. So that's the main indication in Holland now to perform EFTR is for T1 colorectal cancer. So these are the preliminary results. In total for T1 colorectal cancers, we have 331 procedures now analyzed. Of those, 133, so 40% of all, were primary treatment. That means a primary EFTR for lesions suspect for cancer, optically suspect for cancer, or secondary treatment after previous incomplete resection for low-risk T1 CRC in 60% of cases, nearly 200. The medium size of the lesion was 15 millimeters, and 2/3 of the lesions were located in the distal from the splenic flexure, and 1/3 proximal from the splenic flexure. So the technical success rate indicating a macroscopic complete resection of either the scar or the lesion was achieved in almost 87% overall and almost 90% in the optically suspect primary group for T1 colorectal cancer. So these are our technical success rates. And then if we look at R0 resection for the optically suspect lesions for cancer was nearly 80%. And overall 84%, where I have to say that a clean scar without any residual cancers was also included as R0 resection. That's why the secondary treatment group, the R0 resection, was even higher, 87.5%. Then if we look at histology for the optically suspect lesions, turn out to be cancer in 85% of the cases. So indicating that it's difficult, we know that it is difficult to very precisely macroscopically see whether it's high-grade dysplasia or maybe early invasive cancers. We know we're not very good in that. But overall, so 15% benign cases and 85 cancers, of which 9% turned out to be T2 cancers. And we must say, we do in Holland an optically suspect lesion for cancer, even if it looks like it has deeper submucosal invasion, so a JNET type 3 lesion, we still include for a primary resection to get this safe excisional biopsy and look at all the histological features afterwards. In our secondary treatment group, we did find residual cancer in 13.5% of all cases. And that's really the same as we find in literature, that after incomplete resections, the risk for this residual cancer is indeed between 6 and 18%. So 13.5% is what we expect. It seems more complex lesions. So 11 of the 26 in total with residual cancer turned out to be T2 cancers. That's what I would like to show about histology. And then when we look at risk assessment, overall, about 1/3 of the cases were considered low risk from the primary treatment group, and 2/3 considered high risk lesions. If you look at the R0 rates, for a low risk lesion, it was 83.3%. And for the high risk lesions, it was 75.6%. So successful risk stratification was like our German colleagues, about the same, 98.5% we were able to perform complete risk assessment of the lesions. Then the most important, of course, is, I mean, the technical aspects are nice, but what about curative resection? Overall, a curative resection was achieved in over 60%. For the primary treatment group, the overall resection rate was 33%, and the secondary treatment group nearly 80%. But then if you only look at the cases with adenocarcinoma at histology for the primary treatment group, so only the lesions that actually turned out to be cancer, a curative resection during the for the traditional risk features, including deep submucosal invasion as a risk factor for lymph node metastasis, then the curative resection rate was 22.7%. But what we also found is in that half of all deep submucosal invasive cancers, no other risk factors were there for lymph node metastasis, meaning that if we would exclude deep submucosal invasion as a risk factor, the curative resection rate would increase up to almost 54%. For the secondary treatment group, which is, and then only considering not the clean scars, but the actual residual cancers, so there were 26 of those, in over 30%, we would be able to still achieve a curative resection if we would disregard deep submucosal invasion as a risk factor. If we look at the additional surgery after EFTR, that was performed in overall 21% of all cases. So about 80% was not referred for additional surgery. And the main indication for additional surgery was, of course, one or more histological risk factors or an incomplete resection of the EFTR. So these 68 cases were actually, of course, the highest risk group for residual cancers or lymph node metastasis. And then from these 68 cases, only 4 were having actual residual cancer in their surgical specimen. Another, more evidence that surgery for T1 colorectal cancer indeed very often does not lead to, additional benefit for the patients. So if we look at complications, finally, yes, we have complications overall in 8% of all cases for these T1 related cancers. Most of them only account for mild or moderate adverse events. Severe adverse events were there in 2.2% of all cases, and they all concerned perforations. I must say that the majority of those delayed perforations, which I believe is the most feared complications of EFTR, the majority was located in the left side in the sigmoid, and all of these delayed perforations did not receive stool softeners after the procedure. And I personally believe that stool softeners might, by prescribing them, might relieve the pressure in the left-sided colon and might maybe, I hope, decrease this delayed perforation risk of 1.6% in total. So my most important conclusions or take-home messages is that I believe that EFTR for T1 colorectal cancers is here to stay. I believe that the ability to perform a safe transmural resection for T1 colorectal cancer actually can expand the therapeutic possibilities. It's technically successful in 87% of all cases, leads to R0 resection rates that are equal to ESD data. It delivers optimal histology and risk stratification in over 98% of the cases. And I believe it could change traditional treatment paradigms and reduce the overuse of surgery for T1 colorectal cancer. As said, it can provide R0 resection for deep invasive cancers and about half of all deep invasive cancers do not have any other risk factors, and it might give a safe completion treatment for scars after previous incomplete resection for low-risk T1 CRC, of course. We are still young. I mean, we don't have any long-term data yet, and we definitely need them to position to position the place for EFTR in the treatment of early colorectal cancer. Yeah, that's what I would like to tell you.
Thank you very much,
today.
Barbara, for your excellent presentation. Congratulations to all the work you did in this field, in this multi-center setting, and quite interesting results. Although I think your conclusions were quite optimistic.
Yes.
I think one should add that the curative resection rate of T1 cancer was around 20%. And in addition, I think you should also mention the selection of patients. So most of our patients with early cancers have larger lesions. For example, lateral spreading tumor 1S plus 2A. So you have a nodule within an area of a lateral spreading non-granular tumor, for example. We know the risk of cancer is 14% or so. And how to apply FTR in such a case?
Yes, that's absolutely right. The main limitation, of course, for EFTR is the size limitation of I think 2 centimeters. It's definitely the upper limit for malignant cases. It's not the T1 working group in Holland actually looked at the size of T1 cancers. And indeed, about half is smaller than 2 centimeters, and the other half are invasive parts in large laterally spreading lesions. I don't know the exact data, but in my personal experience, I have never encountered a demarcated invasive area that was still T1 and larger than 2 centimeters. So usually it's a very benign lesion, a large laterally spreading benign lesion with a very often a clearly demarcated area that is a malignant, and the whole area around it is benign, but that malignant area and still T1 is, I think, I don't know your experience, but I think very rarely more than 2 centimeters.
Okay, then you combine EMR with FTR, as we have heard before.
This is looking in the very future, of course, but I must say that I'm interested in the hybrid approach for these laterally spreading lesions, especially in the right side of the colon, where ESD in non-Asian hands are extremely difficult. And considering also that most of the T1 cancers that we encounter have deep submucosal invasion at diagnosis. And this poses really a problem because then you actually don't have any other choice than surgery, which well, you know, it's not that we should never send patients for surgery, but if indeed it would be possible to optically really see where the benign part is and where the malignant part starts in experienced hands and within of course a trial, then I think I don't exclude that we would start experience in those cases.
Okay. There is a question, there is a leak rate after conventional surgery. Is the perforation not reflection of a similar process, and how will stool softeners help that?
Well, for the stool softeners, of course, I don't have any evidence. It's just a personal feel that with a wedge, what we do in full thickness resection is we perform a wedge resection in the left-sided colon. So per definition, there will be a relative stenosis at the level of the clip. And well, of course, since pressures and stools are higher in the left-sided colon, then I believe these high pressures can indeed contribute to tissue rupture at the level of the clip.
Okay.
It's
we are already nearly almost out of time, but one question I think is very important. You re-emphasized that the risk of if submucosal invasion of more than 1,000 micron is the only risk factor, then for advanced cancer, then it's probably safe enough to avoid surgery. But this does not meet current guidelines, at least not in Germany. And I think in this case, it's very important that we go get detailed information on tumor budding. And I don't see that for most of the pathologists. How is it done in the Netherlands?
I absolutely agree with you, Horst. And first of all, I would like to stress that there is no long-term safety data on the endoscopic resection for deep submucosal cancers. Of course, we all need to talk to our, we cannot conclude treatment regimens in a multidisciplinary meeting only. We have to talk to the patients as well, and then discussing the risk and benefits with the patient. A patient can, of course, decide not to undergo that surgery, but as the evidence is at the moment, it seems that indeed that deep submucosal invasion is not a strong risk factor for lymph node metastasis, and thus that a safe excisional biopsy is maybe the first step to make. And then, but I totally agree with you, have to be careful to conclude now that we can safely remove deep submucosal invasive cancers, and then the patient is cured, and we never have, we don't have to perform any surveillance or surgery. That's first of all, I would like to stress that point. And the point of tumor budding is indeed also in the Netherlands. It's not included yet in the guidelines because there's a well, for pathologists, they're not. It's not uniformly well. It's the adoption of including tumor budding and also the assessment of tumor budding is still for them difficult to make. So that's another important point I have to make, that for all our primary lesions, the assessment of tumor budding missed in a significant number of the cases.
Okay, thank you very much. Alex, do you have a final question or remark?
I just have one remark to make, that I think it was very interesting, and I think this showed us very nicely also the data from the Dutch registry, that there's really, we are in progress, that maybe the standards we've done today, or we're still doing today, will be the mistakes of tomorrow. Looking forward to more data from your side. Very interesting. Thank you.
Okay, there are still many open questions, but I think it's a fantastic area for research, and also our patients will benefit a lot, as it was re-emphasized by all of the speakers. We have new technologies, very promising, but of course we need an appropriate clinical evaluation and clinical studies for further evaluation. So thank all the speakers, and Alex, it was a pleasure to moderate with you. And
well, you did most of the job. Thank you.
Yes, we thank Ovesco for supporting the symposium. So I learned a lot, and hopefully also our attendants. And thank you for participation, and have a nice evening. Thank you. Bye-bye.
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 Innovation in scope. This is what Ovesco stands for. With keen intuition for the medical need, we develop and manufacture tools to enhance patient care. It all started with the OTSC clip in 2006. But Ovesco does not only focus on clips. This product formed a solid basis for many other technologies. Over the years, our portfolio has been expanded through optimized resection techniques like FTRD and Resect Plus, and also diagnostic tools such as Hemopill and robot-assisted systems. 3,500 products are manufactured monthly in our 400 square meter clean room area. 60 kilograms of nitinol are used per year and brought into shape. The thread length of all OTSC systems sold could easily reach a satellite in orbit. The wire in our DC cutter is processed in such a way that 150 ampere can flow through the 2.6 millimeter instrument. With equal efficiency, our expertise flows into the development of new products. We are in continual contact with users, and it is our vision to close the gap in current therapeutic treatment options in order to maximize patients' benefit. We bring together expertise from different fields like electronics, material science, diagnostic microsensing, robotics, product design, and more. This robot would not be able to function without an intelligent team behind it, and neither would we as a company. Growth is only possible by uniting people and their knowledge. With around 700 publications as clinical evidence, we are proud to be amongst the leaders in the field of GI endoscopy. The randomized controlled STING trial showed that OTSC is significantly superior to standard therapy for achieving successful hemostasis. We offer comprehensive procedures, not only products. The Ovesco team is your companion all the way from training to intervention. Best proof that this concept works is demonstrated by the technical success rate in the German FTRD registry. It reports procedural outcomes of 1,178 patients, showing a high complete resection rate. The FTRD system is revolutionizing the treatment of colorectal lesions by preventing invasive surgical procedures. Bringing together more than 14 different nations on one campus, we serve customers worldwide. From our headquarters in Germany and our offices in France and the US, our parcels are shipped to over 70 countries across the globe. On our campus, we define ourselves as a family, and that includes even the youngest. We think, learn, and grow together. We were very moved by a case of a 6-year-old girl with life-threatening GI bleeding. After unsuccessful surgery, she was admitted to the emergency room. Endoscopic investigation revealed a large bleeding duodenal ulcer. Despite the challenging situation, the placement of a single OTSC clip saved her life. To date, over 140,000 OTSC clips have been used to reduce suffering and save lives worldwide. We see ourselves as pioneers, pushing the boundaries of new technologies. Utilizing our distinct, innovative ability, it is our mission to create permanent clinical value for patients in endoluminal surgery.